So I'm going to go fast through what was mentioned before. I'm consulting for NIDIC and Star Surgical, which are not related to the topic. This is Dr. Anwar, for those who did not met him. I had the privilege to work with Anwar for such a long time. He's a great person, a great surgeon. Now he's retired. And he was, he did this for so many years. He was always on the working mode. And those who saw him operating can appreciate how great surgeon Anwar is. Why we want to do DALC? I think this is, no one will disagree, because we want to preserve the endothelium of those patients who are young enough and have to have their graft for the rest of their lives, especially keratoconus patients. So you do not want to lose their healthy endothelium. And doing DALC, we can use such bad corneal tissues. You cannot use such a corneal tissue for a PK, but you can use it for a lamellar graft. That enlarges the pool of corneal tissue you can use, which is a big issue these days. Why do we want to bear the Descemet membrane? Because if you do anything else, manual dissection, femto-laser dissection, any kind of dissection that do not reach the level of Descemet membrane, you will have this kind of عارف فين البوينتر؟ في pointer. Okay. So you will have this kind of relatively smooth, but you cannot compare what you get with any way of manual dissection or femtolaser or microkeratome with the smoothness of the bare Descemet membrane. That's why there is a big difference in the quality of vision after the surgery. This is an example of a manual dissection. You can see here the OCT a few months after the surgery. You always leave a layer of at least 100 microns. With the DALC, with the big bubble technique, you have nothing left because you're explanting and transplanting the full stroma, so you have a much better quality of vision. With the femtolaser, I tried this many times with different platforms. You can never get close to what you have with the smooth Descemet membrane. With the femtolaser, you cannot reach closer than 100 micron from the endothelium. That's why you will always have a thick, relatively thick residual. So this is an unedited case. I prefer to use this kind of telefination where you have an obturator in the center. This is the Moria Terrifine, because it gives you a limbal suction and a fixation at the center. So you're fixing the cornea from the 2 point and you're cutting in between. That's why your cut is almost vertical. But with the other kinds of Terrifine that have a corneal suction, not a limbal suction, a corneal suction, and no obturator in the center, you're fixing the cornea from 1 point, and then you're cutting. So almost always, you'll have a slanting cut. Now, partial terrifination, you need to be around 300 micron depth. Then this is a cannula that I use. It's from Moria. Again, I have no financial interest. This is the same like the Fontana cannula, but it has no trocar and cannula. You just go with the cannula from the beginning. Again, the opening is directed inferiorly, and you inject. Now, the tip here is you have to see the air emphysema in the stroma before the bubble is forming. Otherwise, you're going to see no bubbles. If you're going to stop every time you see air in the stroma, you'll never have bubble, because a bubble is always preceded by air emphysema. That's a very important tip. You meet some surgeons telling you we never had the bubble, because they always stop the moment they have emphysema. Now, debulking, removing the anterior lamella of the cornea. I like to do this with the eye firm, but you need to be fast, because you can imagine that the pressure inside the eye now is too high. So you need to be fast to remove this. You can always do the paracentesis before the debulking in order to lower the pressure in the anterior chamber if you want to take your time during this stage. Paracentesis, release aqueous from the anterior chamber, and then the puncture. Again, the puncture has to be clean and neat and in one level. Otherwise, you'll find difficulty to find the track from which the air escaped. Now, with the blunt scissors, this is the blunt venous scissors, irregular blunt venous scissors. One of the disadvantages of this procedure is that you don't use many instruments. So the companies are not making much money out of this. So they are not really pushing this procedure. This is regular blunt venous scissors from Moria or from Katina. You can get the same thing. The tip here is to reach the edge of the terifenation. The more peripheral you go with your scissor, the better suturing technique you will have. Then the rest is easy. Once you reach this stage, then you remove the endothelium from the donor. If you're lucky, the endothelium will come this way, but in most of the cases, you have to get it with the sponge. Here I'm going to show you the injection in slow motion. If you go deep enough, you don't have to be at the level of the descemet membrane, but it's enough to be close to the descemet membrane. And then inject the air and watch the air in the stroma, watch the air emphysema. You see now, ready to inject. Watch the air forming in the stroma before the bubble. You see the air comes first and then the bubble. And this happens every time. If you're going to stop every time you see air in the stroma, you will never see a bubble, because a bubble is always preceded by this air emphysema. Now, if you don't have bubble from the first, second, third, fourth dissection, you can always do this debulking, and you can inject air after debulking with a 30 gauge needle, go in the deeper stroma, inject air, and the chance of getting the bubble after debulking is even higher. Some surgeons are actually doing the debulking in every case and then inject in the with the 30 gauge needle after the debulking. Now, this is interesting. If you have a small bubble, I always like to have a big bubble. If you have a small bubble, you can go and enlarge the bubble, what I call the bubble augmentation. So you have a small bubble, you can puncture and go with your procedure, but a big bubble does most of the work for you. Type 2 bubble was already mentioned, so I'm not going to stop here. Yeah, that's more than enough. Now, what if you have a perforation? If you have a perforation, you can do many things, actually. The easiest thing is to put air in the anterior chamber, air tamponade. You can also use the stromal plug, just a small piece of the stroma to plug the perforation, give time for the fibronectin to seal this perforation. An interesting way to seal larger perforation is using the fibrin glue. I tried this for a few cases. It works very well. If you have a large perforation that you cannot seal with air or with a stromal plug, then you can use a fibrin glue. Just give it a few seconds to work, then inject air in the anterior chamber, and you can proceed with your procedure. It takes a little bit longer time. This is the same patient with the fibrin glue, first day after the perforation, and then this is 2 weeks after the perforation. It just disappears. Now, an interesting case, this patient came to me from another country, actually, and she had bulk, and the surgeon called me, and he told me that everything went fine, very nice bulk, and then the first day, a big descemet detachment. He waited for some time, then injected air bubble twice over the first 3 weeks, but the descemet detachment never reattached. So I took the patient to the operating room, removed her cornea, and then this is what I found. Small perforation, and then I've seen viscoelastic coming out, because the surgeon used a visco dissection, and he failed to remove all the visco from the interface. Now, you have visco entrapped between the descemet layer, the remaining part of the stroma of the patient, and the graft. So that was a nice surprise. I removed the graft, went through this track, got the visco out, removed the posterior layer of the stroma that was left, and now we have a bare descemet, and things went so fine. And this is the patient the first day, and that was really interesting. Removing the endothelium is important. Do not injure the stroma. If you're going to injure the stroma, then you're losing the main advantage of the big bubble bulk. So you can strip it easily if the donor age is old, or if not, you can do it with the microsponge, like in this case. Stains sometimes help. The idea is to kill the endothelium rather than removing it. If it's very tough for you to remove the endothelium in a young boy, in a young donor tissue, then you just scrape it and kill the endothelium so you don't have a double anterior chamber. One of the things I'm doing for the last few years is to mark both donor and recipient at the end of the procedure. This makes your suturing really better. At least my suturing helps making the astigmatism much less. I do suture adjustment on the slit lamp 2 weeks after the procedure. Once the epithelium is healed, I can get a topography. After I remove the sutures at 1 year, and then 3 months later, I can do an astigmatic keratotomy with the femto laser in case I have high cylinder. This is a very valuable and very helpful procedure that decreases your astigmatism, at least to the range where the patient can wear glasses, or you can put aphakic intraocular lenses. So to conclude, I think the DALC is the way to go. I don't think it's now accepted to do a PK on a patient with keratoconus who can have DALC. I believe that the big bubble is the best way to perform DALC because it gives you the highest chance to expose the descemet membrane to have a best visual acuity after the surgery, and of course with much less risk of rejection. And if stroma rejection happens in our hands, it happens in about 5% of the cases, stroma rejection, but it's easily resolving with topical steroids. And I thank you for your attention.
Thank you.